We shall now go on to our next speaker, Dr. Anand VINEKAR, who needs no introduction, who heads the Pediatric Retina Services of Narayan Nethralaya, an extremely innovative individual, and he's going to tell us about handheld OCT. On to you, Dr. Anand.
Thank you, ma'am, and thank you, ARC, for this opportunity once again. These are wonderful programs, and I'm so happy to be part of it. I have no financial interest. When we're talking about handheld OCT, obviously we're switching gears here, so it's going to be pediatric, and what better use of a handheld OCT than to image children. Now, historically, of course, it's not been that easy. If you had to examine a baby on OCT, then you had to do this in a lateral decubitus position, most often using either sedation or general anesthesia that was described by Patel's group in Oxford. They also described the flying baby position, which is basically a supine baby with a hyperextension of the neck. These are not easy. As you can see, a whole team there. One is almost biting his nails. So it's very difficult to do in a preterm baby, especially if you want to image it during the time of the acute disease process itself. A few years, maybe over a decade ago, we tried to actually dismantle the Heidelberg spectralis to make it a sort of a handheld, and found that there were laterally inverted images, but we were still able to see what we wanted to see. And in this case, it was the flat neovascularization of partially treated aggressive disease to then target laser exactly on what MB remained. So it was useful, but it was very cumbersome. Also, we breached the warranty in trying to do that. So therefore, handheld OCT is the way to go, I guess. And this was the Bioptigen, which at that time was owned by them, and now it's owned by Leica. It was at the time we had it as a testing tool, it was not even FDA approved, but now I think there are other devices as well. So let's see what we have understood in the terms of quantum of information coming from OCT of these infants. Now, many speakers have alluded to this. This is a supposedly normal OCT of an adult, and one can talk about whether it should be called ISOS or EZ, as Dr. Goel also said. But what's really different in a preterm baby is that there is no fusion of the inner limiting membrane and the outer plexiform layer if you're born especially premature and you're being imaged in the first few days or weeks of life. And also, as you'll see now, some of these layers do not appear at birth and then start developing within a few weeks. Now, this whole process of what we now call fovealization maybe determines not only the way the fovea looks now and then later, but also perhaps influences vision. And that's really what's so important. Now, what I'd like you to do is to train your eyes on the two vertically blue arrows, which is basically the outer, which is the EZ or the ellipsoid layer or the ISOS. And that layer is growing from out inwards. On the top left is the age of this baby. So it's 38 weeks. This baby was born at 32 weeks and imaged 6 weeks after birth. So this is the 38 weeks. Sequentially, we've imaged this baby another 4 weeks later. And you can see now that right at the subfoveal area, there's just one layer, which is the RPE. And then now coming in closer and closer, trying to join itself from both sides is the ISOS. So that's 42. This is 46. 47 is almost 2 layers, and this is 48. Now, this is the same baby sequentially being imaged. So here's the importance of what's happening here. So this is a sort of a centripetal growth. Now I'm going to reverse these slides and go back here. Since all of you all were trained at the lower end of the image, now train your eyes at the superior end where the inner retinal layers are. And look at this outer plexiform layer that's really sagging below, almost touching the RPE. And now see what's happening there. Again, now don't look at the blue arrows, look up. And you see now that the outer plexiform layer is right there. It's moving up a bit, but all the inner retinal layers in that foveal center are actually moving out. So at 48 weeks, you now have a very firm fusion of the ILM and the outer plexiform layer. So critically, two things are happening here. One centripetal and the other one centrifugal. And I think both of them are probably happening at the same time. There's a lot of debate. This was one of our early reports saying how early can you see some of these layers like the external limiting membrane, and how significant is that to the vision itself. The Duke group has taken this to another level where they've actually looked at all these OCT changes and said that some of these layers actually correspond not only to the postnatal life, but also histopathologically. And this was their study in which they looked at the OCT layers and they diagrammatic representations of which and then correlated with histopathology. We did what we did was look at these babies who had otherwise normal looking maculas, otherwise all common risk factors. They only differed in their OCTs. So the one on top was a 3-month-old corrected baby with 20 by 1400 vision on the telar acuity, and all other factors same, just with a better looking OCT. And by better looking, I mean now that the centripetal layer has completed itself and the inner retinal layer has moved out and there's a good fusion, and that baby has a 20 by 540. We thought it was anecdotal, and so then we extended our study to look at all these layers. So the inner retinal layer migration, that's what it's called, IRL migration, the appearance of the external limiting, the ISOS junction, what time they appear, how late can they appear in postnatal life, and how does that determine vision itself. And of course, does ROP influence all of this? So with babies with ROP, does it delay this process? Do some layers not come in at all? While we were trying to do that, we kind of serendipitously discovered that there was some sort of a disruption of these inner retinal layers, what we at that time called macular edema, which is now popularly called macular edema of prematurity. And we found two patterns. And these patterns were either the so-called classical adult CME appearance, where the foveal center is lost, there's a lot of intracystic spaces, there are high vertical reflective septae, and pattern B, where some amount of the foveal depression is preserved. There are a few septae, there is some inner retinal disorganization, so to speak, which extends beyond as well. But what was so interesting is that this peaked at around 37 to 40 weeks and went away by about 52nd week. When we followed these babies and said, okay, this was transient edema, did it do anything to them at all? And when we compared these three groups, with and without edema, we found that the babies who had the edema had poorer vision for the first 3 to 6 months of corrected life, and only after vision therapy and vision stimulation by the age of 12 months, as you can see from this graph, that they equalize. And at that point of time, pattern A and pattern B did not matter. Switching gears in terms of OCT, and one of the speakers mentioned that sometimes you're able to see a lesion much better on an OCT than a clinical image. And I think this case of tuberous sclerosis and hematoma is a classical example. So here we were trying to show that there are different patterns that show up both on an angio and on an OCT. Some of these lesions light up on an angio, some of them don't, but almost all of them are picked up on the OCT, however small and clinically insignificant. Continuing on that foveal morphology and vision, this slide, this picture from our publication sort of summarizes it. So if there's no fusion, if the outer plexiform layer is attenuated, if the ISOS has not fused, if the foveal tent is either absent or delays, all of these, especially seen in babies with ROP, can determine poorer vision, which basically means that fovealization is not happening. In older children, as your pediatric ophthalmology colleagues might send you, they have patched, they have found that the refractive errors are not very different. There's not much of so-called anisometric metropic amblyopia. But when you do their OCTs, you find, and you can clearly see one eye here is 6 by 6, the other eye is 6/18. Patching has been done for months, if not years. And you see how thinned out that ellipsoid layer is, the interdigitating zone is. And one can tell that there is something that probably went wrong from a substructural point of view, but not from an ophthalmoscopically point of view. This is our publication on rubella and its OCT findings. I just want to bring your attention to this tooth-like jagged appearance of the outer plexiform layer, and then we found some other irregularities. The so-called salt and pepper retinopathy was not as obvious on OCT as we would have thought, but there were more changes in the inner retina itself. Down syndrome has been one of the focus of our work. What's really interesting in OCTs on these children is that they sort of resemble normal controls. In other words, children without Downs up to the age of 2. And after 2, they start showing either stagnation of their foveal layers or actually regression patterns of some of their foveal layers. And that's really interesting because that's the time where some of their higher mental functions also take a hit, and higher order imaging of neuroimaging has shown that there are some tangles that appear after the age of 2. So is OCT of the retina mirroring what's going on in the brain? That's an interesting question. I'm just going to end with this OCT angiography study, and I know there's a separate segment of it, but in preterm babies, when you look at controls, babies who've had treatable ROP and those who've had spontaneously regressed ROP, despite having good vision, I mean 6/9 or better, and this cohort was age 5 to 10, they had abnormal looking OCT angiographies. We published in the IGO a few years ago, what are the other aspects where a pediatric OCT can be used, right from suboptimal vision to intraocular tumors, miscellaneous lesions, vascular lesions, and so on. To summarize, handheld OCT is obviously the bedside advantage. It's a tool in your hand to image small babies. It allows you subclinical assessment, as we saw in some of the examples. It definitely improves our understanding of diseases. And the most important thing is if we can predict which of these findings will have a potential for predicting vision, then that would be really good. Thank you so much.
Thank you very much, Dr. Anand. Nothing less was expected from you. Amazing talk. Dr. Srinivas, any questions?
Anand sir, as usual, wonderful talk. So we find difficulty in just imaging the periphery with the RETCam. So how easy do you find in imaging these periphery, especially whether to know that it's a vascularized, whether it's a regressed, using the handheld OCT? And secondly, I should really appreciate your this thing of dismantling that Heidelberg spectralis and trying to see that. I think nobody from here don't have the guts to do that kind of sort, because we don't know whether it works back or not. But my basic question is first about the imaging of the periphery, especially in zone 2, zone 3 areas.
So, Srinivas, I don't think we need the OCT to image vessels in the periphery. Using an OCT, so that our RETCam or our NEOs are sufficient. What we were trying to do there is to, our focus of research at that time was to see these stage 2 ROPs that were not regressing. And they were going on for 50, 52, 55 weeks. So we wanted to see whether they had some characteristics of why they were not resolving, whether there was some sort of an active stage, whether there was vitreopathy, or whether there were changes subretinally, and so on. So in that extent, because this is a non-contact device, you need an assistant, of course, to hold the head. And the imager will need a depressor many times to be able to bring that part of the retina into focus for if you want to image the pre-retinal changes. But honestly, we don't need to look at vessels on OCT in the periphery.
Dr. Jatinder?
I think just about Srinivas's question, I think not many people have tried that dismantling of the Heidelberg, because the company personnel, they mentioned specifically that it voids the warranty after that. So
So we did breach the warranty. We told them, and then after it got published in I, they restored the warranty and then went on to develop a handheld, and they cited our paper and they thanked our management for the same.
Thank you very much. So
I just have one question, Anand.
Yes.
So, do you find this in particular like some use in macular dystrophies? So for example, where you are expecting certain changes in the offspring, say for example autosomal dominant some dystrophies, where you can do in the infancy period, so OCT,
Absolutely.
and actually give a prediction, just like ERG gives prediction only after 5 years.
Correct. So I think great question, and we've been reducing the number of electrophysiology tests that we've been doing at ANAND, predominantly because we rely so much on the OCT itself. So we are able to decide whether it's rod, cone, and based on how much choroid is lost, how much differentiation is there in the inner retina, even now start correlating slowly with their genotype. So right, it's a great tool to detect inherited retinal dystrophies as well.
I think we'll need a good normative database as well. I'm sure you would have been working on that too.
Work in progress.